Hello, I am Mark Alexander from the Parkinson's Support Group of Sonoma County, and I'd like to welcome you to our first virtual meeting via Zoom. In the future, we may try to have our breakout groups, but today we have just our featured speaker. Today's presentation is by Dr. Zuzuarregui. Dr. Zuzuarregui is an assistant professor of neurology at UCSF. He completed a fellowship in movement disorders at Boston University and sleep medicine at Stanford. Today's talk is entitled, What a Night, Sleep in Parkinson's Disease, a discussion of behavioral, pharmacological, and surgical treatment. Our recording begins with Dr. Zuzuarregui discussing 2 clinical trials at UCSF that are operating by telemedicine during the current practice of social distancing. Thank you very much.
And we'll be talking about, again, sleep in Parkinson's disease today. I'm sure many people in the talk are familiar with what Parkinson's disease is, but for many decades, Parkinson's disease was really seen as a motor disorder where people presented initially with a symptom of tremor in their hand, particularly at rest, but also, when using their hand, what we call bradykinesia or slowness of movement, where they just weren't moving as fast as they used to, rigidity or stiffness, as well as problems with walking, where you slow down and feel that your balance is off. But in the past 20 to 30 years, we really have come to realize that Parkinson's disease is far more than just a problem with your mobility and your movement. And so there are many what we call non-motor issues in Parkinson's disease that can affect patients and their quality of life. Frequent urination is one of them, which can happen during the day or at night. Constipation is another that can many times precede the diagnosis of Parkinson's by many years. Mood disturbances, which I would categorize as things like anxiety, depression, hallucinations, can also occur in Parkinson's. And then sleep difficulties, which there are many causes for sleep problems in Parkinson's disease, and we're really going to focus on this today. There have been a few studies that have surveyed patients with Parkinson's disease, and about 80% of patients have said that they experience some sort of difficulty with sleep. And the main complaints that people have are that, number one, there's a reduction in how long you sleep during the night. There's an increasing length of time to fall asleep, meaning that when you're in bed, it's just hard to fall asleep right when your head hits the pillow. And then there's also a reduction in what we call deep sleep, where people are just, awakening frequently during the night and they don't feel rested in the morning. So you could imagine that, if there's there's 34 people in this talk, there's probably about 26 people who have sleep problems out of those, the folks in the talk today. So we're going to talk about the different the different issues and what causes disruption of sleep in Parkinson's disease. One is that, this can be caused by sleep disorders, which we'll talk about. Mark, I think you emailed me about REM behavior disorder and restless legs, which we will touch on today. But even, the motor symptoms of Parkinson's disease, like tremor, stiffness in particular, can disrupt sleep during the nighttime, and patients may either have that as they're going to bed or wake up with these symptoms. And then finally, the non-motor symptoms that I briefly touched on earlier can also cause disruption of sleep in Parkinson's. So we'll talk about all 3 of these things during our talk. And so as we focus on sleep, why is sleep in Parkinson's disease so important? And the reason why it's important to get a good night of sleep is even without changes in your medication, I've had patients who, when they optimize their sleep, have improvement in their tremor, have improvement in the stiffness that they feel. There are some patients who experience what we call dyskinesias, or extra movements related to too much medication or a reaction to the medication. It can also improve your daytime energy and your motivation during the day. It can also improve your cognition and ability to think and to function during the daytime. So this is something that, that I in particular try to focus on in my patients and try to optimize rather than adjusting other medications to treat these symptoms. And so today's talk really is focused on practical strategies for identifying sleep troubles and then how to manage these. And One thing I like to say at the beginning of all my talks is that if we talk about medications, these are mainly for your information. And I would highly recommend that you discuss any medication changes that you're considering with your treating physician. But this is to serve as sort of a springboard for that discussion with your neurologist or your primary care, whoever is managing your Parkinson's disease. And so the outline for the talk today is to focus on sleep disorders resulting from Parkinson's disease. We'll also talk about common symptoms of Parkinson's disease, both motor and non-motor, that impact sleep. And then we'll also talk about a common sleep disorder that can impact Parkinson's disease as well. So getting into the sleep disorders, the first one that I think people commonly experience is what's called insomnia. And, this picture shows a gentleman who really, you can see the bags under his eyes. He's having a really tough time, falling asleep, and he looks very, very fraught about this whole situation. And many people experience that. And the way that I like to describe insomnia is that it's a problem with falling asleep. And it's very common in Parkinson's. About 50 to 60% of patients do have trouble falling asleep. And 40% of these patients are on some sort of medication to try to address this issue. And when patients have trouble falling asleep, it can be related to a number of issues that we'll talk about today. But in particular with insomnia, mood disorders can worsen this. And patients who may feel depressed or may feel anxious, that can really impact your mind and how active it is as you lie down to sleep at night. And so many of the patients that I see who complain of feeling depressed or feeling anxious also complain that they have insomnia, and it can be a tough cycle to break. And so the impact of insomnia on Parkinson's, of course, is that it can cause a late night if you're having trouble falling asleep. For some patients, I've even heard that they wake up in the middle of the night and their mind is simply racing about their thoughts, for what's going to happen in the next day or what happened in the previous day. And as a result of those awakenings and trouble falling asleep, motor symptoms of Parkinson's disease can worsen. There also have been studies that have looked at the cognition of patients, who deal with insomnia, and they have trouble with things like their short-term memory. When somebody talks to you the week before and has asked you to do something, you forget what they asked you. And then there's also, a problem with navigating how you get around, your day-to-day life in the house or outside, your visual spatial functioning, or how you get around. So all of those things can worsen as a result of insomnia, and even more reason to try to address this. So, I like to stick to really the behavioral changes or recommendations first before trying any sort of medication. So, we'll talk a little bit about sleep hygiene here, and this is really important to help create an environment for yourself in order to fall asleep when you get into bed. And, we live in a world that's 24/7, and that really is full of technology. And so, we have iPhones, we have laptops and TVs, and folks often, take this into their bedroom and they watch, TV while they're in bed. So, what we recommend to people is to turn off those devices about an hour before bedtime. And the reason why we recommend that is because the blue light from those devices actually stimulates your wakefulness system to keep going. And it can make it hard to fall asleep if you're continuing to expose yourself to that, to the blue light from these devices. Another thing that we talk about in sleep hygiene is to make your bedroom strictly for sleep and sex. You really shouldn't be eating in your bedroom. You shouldn't, create a workspace in your bedroom. Having a TV in your bedroom can make it difficult. Now, I say all these things, but practically speaking, I live in a small apartment in San Francisco, so that can sometimes be challenging to make your bedroom just for sleep. But for folks who live in a house, this can be a lot easier. And really, what it does is it creates an environment for you when you get into your bedroom that is just for sleep. Other things that can be stimulating to the body and to the wakefulness system are working close to bedtime, which stimulates your mind; eating, which turns on your body's metabolic system, as well as exercising, which does the same thing. And so we try to ask people to avoid doing these close to bedtime. I would say for work, we probably, want people to turn off, their devices or anything that they're working on about an hour or two before bedtime. Eating and exercise, we generally recommend about 3 to 4 hours, stopping 3 to 4 hours before bedtime as well. And then finally, another thing that can help, with creating a habit for yourself of going to bed on time is to establish the same wake time and bedtime every day. And so an example of this would be, if you go to bed at 11, make that your bedtime, and then make sure that you're waking up at, 7 a.m., for example, if you need 8 hours of sleep. Every person is going to be different with how much sleep that they need. So this really is kind of independent to the patient and how much they really need to sleep. I had a patient yesterday I saw over Zoom who told me that, she sleeps 12 hours. So she should set her bedtime and wake time accordingly, so she's not disrupting her cycle. And I would recommend that for other folks as well. There have been a couple of new treatments for insomnia, actually. One is what are called blue light therapy glasses. And I mentioned earlier that when folks are using devices like a laptop, an iPhone, or a smartphone, the blue light from those devices can stimulate you to stay awake. And so what these blue light glasses do, or they filter out the blue light and allow you to get better nighttime sleep. They're also, I should mention that, on your iPhone or on your device, many times they have now what's called a nighttime filter, where you can find that in your settings, and the device itself kind of filters out the blue light from the device. So that's another thing that might be helpful. And then finally, from a physical standpoint, all of us have heard about how exercise and movement in Parkinson's disease is the one thing that's been shown to slow down the progression of disease. Yoga and exercise both have been shown to improve the ability to fall asleep at night. And part of this may be related to improving mood if people are feeling depressed or anxious. But there's something about the chemicals inside your brain that yoga and exercise release that really help people to feel better and are able to fall asleep at night. And, within the Parkinson's disease community, of course, rock steady boxing is a very popular, exercise format. I don't know if you guys have that up in Sonoma, but down in Fresno, there was a rock steady boxing. And so, these are all things that can be very helpful. And again, on the last slide, I mentioned that you probably want to avoid doing exercise at least 3 to 4 hours before bedtime so your body can really calm down from that and allow you to fall asleep. Moving on to another behavioral therapy for insomnia is called cognitive behavioral therapy. And this probably is the most beneficial of all treatments for insomnia and Parkinson's disease. But, I do recognize that that patients in remote areas may not have access to this. So I wanted to bring to light an application that was developed out of the VA hospital with the help of Stanford called the CBTI Coach. And CBTI stands for Cognitive Behavioral Therapy for Insomnia. This is an application that you can download on your iPhone or your Samsung or mobile device. And, it really goes through a lot of what we've already talked about, sleep hygiene and how do you make your environment ready for sleep. But it also provides different behavioral and relaxation techniques to help you really calm down your mind on a consistent basis to help you fall asleep, more quickly. I bring that up because that is free. These other two websites that I'm listing here are cognitive behavioral therapy websites specifically for insomnia. But these actually cost, about $200 to $250 for a 6-week course. And so, of course, I want to list this as an option for people who may not have a person in town who can perform cognitive behavioral therapy. And so I would say, if the CBTI coach isn't working for you, it may be worthwhile to explore these other options. Now, Mark, I think you wanted me to talk a little bit about medications for specifically for depression and anxiety and how that impacts insomnia. And so, really, again, I want to bring up that discussion with your physician about these things is key. And it may require a referral to a sleep medicine specialist or to somebody who deals with, depression and anxiety specifically. The medications that we commonly use if somebody is describing that they have feelings of depression or anxiety, are categorized as SSRIs or SNRIs. And that stands for selective serotonin reuptake inhibitors for the first mnemonic. And then the second one is a serotonin norepinephrine reuptake inhibitor. And the names of these, really just describes the kind of chemical within the brain that these medications are targeting. If somebody comes to me and says, "Hey doc, I'm experiencing, feelings of anxiety on a daily basis and it's really impacting my quality of life," that triggers me to say, well, is it worthwhile to treat? And it's a decision that I want to make together with my patient rather than just forcing a medication on them. But if my patient says, you know what, it is impacting my quality of life, doc, and I really would like to try something, then some of the common medications that we usually try are listed here. One is escitalopram, one is citalopram, which is a sister medication, sertraline, and venlafaxine. There certainly are other, antidepressants and anti-anxiety agents out there, but as a movement disorder specialist, we like to stick to medications that have the least, sort of the least amount of side effect and the least risk of getting addicted to these things. So those are the ones that I generally try first. And again, there are others, which can be discussed with your treating physician. Now, there are a lot of people who, when they are experiencing with insomnia, have a lot of trouble with this and are looking for a quick fix. And I'm sure many people have seen commercials, for things like Ambien or Lunesta, which are sleep aids that specifically are designed to help people fall asleep. And I really try to avoid these medications in patients with Parkinson's. And the reason why is because, there actually have been studies that have looked at long-term use of these medications for insomnia. And there actually may be a risk of causing cognitive decline, which is already, a feature of Parkinson's disease. So if at all possible, I really try to avoid using these type of sleep aids. I listed Ativan on here, or lorazepam, which is in a class of medications called benzodiazepines. And those also have a similar risk of creating cognitive decline in the long term. So if I am going to use these, I really try to just use them on a short-term basis, and then try to really target whatever the underlying issue is that's causing a patient to have trouble falling asleep. So I hope that answers the question. I can't see the chat function right now, Mark, since I'm sharing my screen. Let me just see if I can pull it up here. I don't see any questions at this
No,
point.
I don't either.
Okay, well, this might be a nice time for us to remind folks that if you do have questions, please input them into the chat function, and we will try to address your questions as we go. I'll pause here, and Mark, do you have any questions that you think the folks might want an answer to?
No.
Okay, great. Well, I'll go ahead and move on then. Restless legs, which is a very common sleep disorder. It's kind of hard to, to depict restless legs in simply a picture. But what I wanted to do was show a picture here of somebody who has been thrashing all night. And you can see that the sheets here are pretty wrinkled up, and the legs are now sticking out from the blanket. So maybe next time I'll try to put a video in there so folks can see what it looks like. But restless legs is a disorder that can sometimes be hard to describe for patients, but I've heard things like creepy crawlies, numbness, tingling, my legs are asleep, my legs are jumping or jerking. In order to be diagnosed as restless legs, this really needs to occur at nighttime, or if it's happening throughout the day, to get worse at night. It gets worse with rest or inactivity. For example, if you sit down in a chair to watch TV in the evening, or if you get in bed to fall asleep, you might notice that these symptoms kind of pop up. And then activity or movement of the legs seems to improve these symptoms. And, I hear very commonly from patients, I get into bed at night, doc, and all of a sudden my legs just, want me to move. And it's an urge that I have to move my legs, and I have to get up and walk around to get rid of the sensation. But as soon as I get back into bed, then the sensation comes back. And that's a very common story. This disorder is common in Parkinson's disease, and somewhere around 20 to 34% of patients may experience restless legs. And that may be even higher, as we're asking more questions from our patients with Parkinson's about this. And so the impact of restless legs on Parkinson's disease is that, number one, it can cause significant discomfort. oops, let me go back. It can cause significant discomfort, cause people to wake up in the middle of the night with these symptoms. And if you're, having trouble falling asleep, if you're waking up in the middle of the night, your cognitive function and sleep quality certainly are reduced compared to those without RLS. And that was actually studied in a group of patients with Parkinson's who had restless legs versus patients with Parkinson's who did not have restless legs. Let me pause here because it looks like we have a question. So the difference between restless legs and dyskinesia, and that's from Stuart. So dyskinesia actually is an involuntary movement that typically happens soon after you take your medication for treatment of Parkinson's disease. And, these medications can be anything from Sinemet or carbidopa-levodopa to things like pramipexole or ropinirole. You take the medication and, within 15, 30 minutes, a patient may experience an involuntary wiggling type movement that looks almost like you're either fidgeting or you're dancing to a certain degree. That can happen all throughout the day and typically is related to your medication dose. Now, a differentiating factor between dyskinesia and restless legs is that for restless legs, there's actually an urge for the patient to move their legs. And again, it typically happens at nighttime and is not necessarily related to medication. So a common story from patients that I brought up earlier is that, let's say they sit down in their chair to watch TV at nighttime, they want to watch the evening news. And all of a sudden, as they're sitting down, they feel this buildup of needing to move their legs. And it could be, that they have to move the legs or get up and walk around in order to get some sort of relief of that symptom. A patient with dyskinesia will not feel an urge prior to the movement. And the movement can happen all throughout the body, in the arms, in the face, in the trunk and the legs. Whereas restless legs specifically, I should say, generally occurs, in the legs and sometimes infrequently in the arms. Now, Bo Davis says, if you have RLS, there's no mistaking it. And you're right. This is a very unique symptom that patients experience. And it really, it's really uncomfortable. I've actually found that patients with mild dyskinesia or even moderate dyskinesia may not notice that they have these involuntary movements, whereas patients with RLS certainly do know that they have some sort of discomfort. That's a great point, Bo. So the diagnosis of restless legs is made clinically, actually, based on the symptoms, and it has to require those 4 criteria that I mentioned in the first slide. One is that it's an urge to either move your legs and or your arms. It is worse with inactivity. It gets better with activity and typically happens at nighttime. And so this is important to bring up with your neurologist or even your primary care, because as Bo said, this is, when you have restless legs, it, and it can really disrupt your sleep. And so the treatment of restless legs, I think for people with low iron levels, iron supplementation has been shown to help. And a typical iron supplement would be, an over-the-counter from CVS or Walgreens, where it's a supplement called ferrous sulfate. You can get that over the counter and take it. But again, if you do have restless legs and you're found to have low iron levels, then you should talk with your physician about, how much iron to take and how to take it. In terms of medications for restless legs, I generally start with something called gabapentin, and that's my recommendation for the first medication to try. And gabapentin has been long used in neurology for multiple reasons. One is for treatment of seizures, one is for pain from what we call neuropathy or nerve damage, which is very common in diabetes. But this medication really has a low side effect profile. I think it actually can be quite useful for treating restless legs, and can also sort of have a secondary side effect of helping you fall asleep at night. So sometimes, that can be helpful for people. Horizont is a long-acting form of gabapentin, which many insurance companies require you to try at least 1 or 2 medications before actually starting on this medication. But as I mentioned, it's a long-acting form of gabapentin that in clinical trials has been shown to actually help patients reduce the amount of restless legs that they have. And the side effect profile is very similar to that of gabapentin. Finally, Lyrica or pregabalin is another medication that's similar to gabapentin, but I find a little more potent. And this has also been shown to be effective for treatment of restless legs in clinical trials. And you know, the side effects that you look out for, of course, are sleepiness and it may cause some confusion. So it's important to, you know, speak with your physician about the right medication for you. Now, there's another question that popped up. I have it only when I forget to put on my Nupro patch. Yeah, so Bo, that's actually the next slide, is talking about other treatment options for restless legs. And, you know, patients with Parkinson's, as I mentioned earlier, are treated with medications like pramipexole, ropinirole, Sinemet, and then what's called the Nupro patch, which is the brand name for retigatine. All of these medications here are considered dopamine replacement medications, which is one of the main problems in Parkinson's. But even in patients who just have restless legs and do not have Parkinson's, these medications can be very effective for, you know, for treatment of restless legs. One of the things, however, that's been shown in the past, I should say maybe 5 to 10 years, is that there may be a paradoxical worsening of restless legs if you've been on these medications for a period of time. And the term for that is called augmentation. It seems to be directly related to taking these medications, which, you know, can be challenging for patients with Parkinson's who are already on these for, you know, another reason. And so that's sort of the basis for which my recommendation for trying gabapentin first comes from, is that with these other medications, you know, gabapentin, Horizon, and Lyrica, the risk of paradoxical worsening of your restless leg symptoms is actually low to none. And so, you know, it just kind of depends on your situation. Nupro is very effective for restless legs. All of these have been, you know, proven in clinical trials to help with restless leg symptoms. So, you know, just because there's a potential side effect for worsening doesn't mean that you have to change your medication right now. But I just want people to be aware of that if they are experiencing that. Okay, so REM behavior disorder. So this is a patient with REM behavior disorder, and he'll demonstrate what REM behavior disorder looks like. I don't need to tell you. Mark, were you able to see that okay? Okay, good. So, you know, this is actually a video of one of the first patients that was diagnosed with REM behavior disorder. And, you know, if you go back to that original study, that was done about almost 35 years ago now. So it's a relatively new, you know, a relatively new disorder that we deal with. And this is a disorder where patients act out their dreams. And you can see that gentleman started out with a flicker of the hand and then eventually moved to a more complex behavior of actually getting up and thrashing around bed, and he ended up kind of thumping the bed there towards the end. And I often find that, you know, the behaviors can be anything from simply moaning or groaning during sleep, talking, to yelling, screaming, and then actually acting out these dreams, as you saw in that video. You know, the behaviors are often very violent, and you could see that he was attacking something in his dream. And this is actually quite common in Parkinson's disease. I think the 15% I've written on here is quite low. That's probably from earlier papers where, you know, movement disorder specialists maybe weren't recognizing this quite as often. I think it's probably closer to 40 to 50% of patients with Parkinson's have REM behavior disorder. Let me show you another video here that I have. Let me play that again. Yeah, so this poor patient actually, you know, fell out of bed and hit his head. And I think that really demonstrates sort of the dangerous behaviors that can happen as a result of REM behavior disorder. And, you know, it can affect the patient by increasing the risk of fall out of bed or fractures. And this patient hit his head and then did fall out of bed. And you know, that's really quite scary, not only for the patient, but for, you know, for a bed partner. And similar to the first video that I showed you, you know, patients may have behaviors like that where they kick or hit their partner. And I've had some partners say, you know what, I've been kicked and punched in the face as a result, you know, of my partner's behaviors. And when I woke them up, they had no recollection of what happened. So there really is no control over the behaviors because they're happening during your dreaming state and you're not awake. You know, there have been some studies that have looked at the impact of REM behavior disorder on, you know, on Parkinson's overall, and it does seem that some cognitive impairment can occur as a result of either awakening because of REM behavior disorder or simply from the underlying disease process. And, you know, some difficulty with attention, trouble with finding words in order to speak fluently, as well as short-term memory can occur with REM behavior disorder. I have one last video to show you, so let me. So you can see that, you know, the behaviors are quite violent and there's a high risk of injury to oneself. Mark, I think you had emailed me, how do you diagnose REM behavior disorder? And, you know, a definitive diagnosis is typically made with an in-lab sleep study, meaning, you know, a sleep clinic where you go and spend the night and you're hooked up to a number of different monitors, as well as a video recording in order to diagnose this. But, you know, given COVID, I think most sleep labs that I'm aware of have shut down. And so I think, you know, a clinical diagnosis can be just as effective. I think especially if, you know, you're a patient with Parkinson's disease and you're having symptoms of, you know, talking, yelling out during sleep, you know, moving around frequently or kicking or hitting. You know, there have been a number of questionnaires that have been validated to diagnosis in patients. So I think also given the fact that REM behavior disorder occurs so frequently with Parkinson's disease, you can make that diagnosis pretty readily just speaking with a patient. So in terms of treatment, I mean, the first thing that I talk about with patients is creating a safe bedroom environment. And, you know, the gentleman in the last two videos had his nightstand that had a sharp edge right next to his bed. Oftentimes we'll talk about removing furniture from the bed. Some patients may even need to put up bed pads or bed rails in order to prevent them from falling out of bed. You know, there are some, you know, some parts of California in the country where people readily have knives and guns in their bedroom. And so removing those weapons, you know, from the primary bedroom or placing them in a safe, I think can be a way to prevent, you know, someone from actually using these, even if they're, you know, in a dream state and having a very violent dream.
That'd be scary.
And then, yeah, it's actually quite scary. And so other people also sleep alone or in separate beds in order to avoid being injured. And you know, that's a very common story that I hear from bed partners, is that because of the frequent movement or the violent behavior, they have to move to a separate bed.
We're muted.
Now, treatment of REM behavior disorder, you know, Mark, I think you had asked sort of what's the threshold for someone to be treated. And I think, you know, if somebody is kind of just talking during sleep and kind of mumbling, you know, that's not really that bothersome. And I think if the quality of life or the caretaker is not bothered by that, then I think you can probably get away with not treating this. But I have a very low threshold to put patients on treatment for REM behavior disorder, especially if they're yelling during sleep, if there, you know, is a moderate amount of movement that they're experiencing. And my, you know, my first medication that I recommend is actually a supplement. It's not even a medication, and that's called melatonin. Melatonin can be easily found over the counter, you know, at CVS or Walgreens. And this is actually the one treatment that's been shown to actually help to control the behaviors at night in an effective way. And so I generally start with 3 milligrams of melatonin and can go as high as 15 milligrams. You know, I do that slowly, but depending on how violent the behaviors are, kind of dictates how fast I recommend to increase the medication. But that can be, you know, that can be very effective. And there really are minimal side effects from melatonin. I think most patients have told me that if they do have a side effect, they might feel groggy in the morning when they wake up. And to get around that, I generally recommend that, that the dose of melatonin be moved about an hour earlier into the evening when you take it. Clonazepam has also been studied. Now, this is a benzodiazepine that we kind of discussed earlier. And, this has also been shown to be effective for REM behavior disorder. And I often reserve this, for very severe situations because of the impact it may have on someone's ability to think clearly. The main side effects are people might feel fatigued or sleepy. They might feel that their thinking is slow. So I generally reserve this as sort of the second medication that I try. There are a whole bunch of other medications that have been suggested to be helpful for REM behavior disorder that we just don't really know if they help or not. But there is a clinical trial happening at Stanford, looking at a new medication for treatment of REM behavior disorder. And, this clinical trial is specifically designed for a patient who has tried either melatonin or clonazepam and is not getting effective results, for treatment. So I believe if you put in Stanford University clinical trial REM behavior disorder, it should pop up. My friend Emmanuel During is actually in charge of that trial. So hopefully that provides some good results. All right. So now that we've talked about the sleep disorders that result from Parkinson's disease, let's talk about some of the common symptoms of Parkinson's that impact sleep. Before I move on, there's a couple of questions here. So my husband Michael is in that trial, which is great. Yeah, I think Dr. During is a great person, and he's a good researcher. So hopefully that shows something. And then Nancy asked, do you recommend melatonin every night? And I would say, if the behaviors, I'll take a step back. If the behaviors are, related to REM behavior disorder, if they're happening, once or twice a week, it may not be worthwhile to take melatonin that frequently. But if they're happening 3-4 times a week, then I would recommend to take melatonin every night. And that generally is the recommendation for clonazepam as well. It's often difficult to predict when these behaviors are going to happen. And so, it's just worthwhile to just take it every night in order to prevent them, especially if they're affecting the quality of life of, the bed partner or the patient themselves. So one of the symptoms that can result from Parkinson's disease is called nocturia. And this is a symptom of having to get up to urinate at nighttime. And you can see that this figure is running to the bathroom at night because they really have an urge to, to urinate. And in Parkinson's disease, this can be related to involvement of bladder control, from the disease itself. But, there are a lot of other issues that can contribute to getting up at night to urinate. One is an enlarged prostate, which is common in men. Some people have sleep apnea, which can cause you to urinate at night. And so, those are other things to consider. But this is a disturbing symptom in that it can occur multiple times a night and really disrupt your sleep. I've had some patients who have told me, doc, I get up 7-8 times a night to urinate, and I really don't feel like I can get quality sleep. And you could imagine that waking up 8 times a night, it's just really disruptive. And so it's an important symptom to really focus on and try to treat. The diagnosis of nocturia really, at least from a neurologist standpoint, is clinical, but as just a discussion with the patient about, I'm getting up at night to urinate. But as I mentioned, there are other issues that can lead to, to this urination at nighttime. And so, again, I generally refer to a urologist in order to just take a look. Is there an enlarged prostate? Is there something else that might be causing this issue? And kind of partnering with the urologist on treating that. Now, as a movement disorder specialist, we do recognize, urinating at night as a symptom of Parkinson's disease, and we are able to treat that with medications. And I've listed 3 here that we commonly use. And the reason why I listed these 3 medications is because they actually have the lowest side effect profile of many medications that are used to treat frequent urination. So Sanctura is one of them. Myrbetriq is the second, and Vesicare is the third. And these medications, really what they do is they help your bladder to relax. So it fills up with urine. You could imagine that if your bladder is a big muscle or a balloon, and if that balloon is not very large, once it fills up, you're going to have to empty that balloon. So really the idea behind these medications is to let that bladder enlarge, let it to become a bigger balloon so it fills up and you don't have to empty as frequently. Now again, as I mentioned, there are many other medications that can be used, but have side effects. And so, I just try to take a look at the list of medications you might be taking for urination and see if there are any that we can change to the 3 that I recommend. Of course, if you have an enlarged prostate, I would let the urologist make a decision about what medications to try, because that's a different issue than bladder involvement from Parkinson's disease. And then finally, a urologist, as a partner in treatment, may recommend, Botox for your bladder. And this generally is reserved for people who have tried multiple medications, who are having frequent urination at nighttime. And, Botox is a medication that can be used to relax the bladder, which is a big muscle, and allow it to fill up, allow that balloon to get bigger so you don't have to empty it as often. But that's really more kind of a last resort. We really try to stick to medications first. Now, in terms of just sort of practical management of frequent urination, I do have some patients who have said, "Doc, you know what? I don't want to take any meds. I'd rather just wear a condom catheter," and this is for men, wear a condom catheter at night so I don't have to get up out of bed and use the restroom, and that's fine. I've had other folks who really have problems with their ability to get around, and just say, "You know what? I'm just going to wear Depends, and when I get up in the morning, I'll change my diaper, because it's too hard for me to get out of bed, and there's a risk of me falling." And I think either of those are fine. The treatment for any of these issues really depends on you as the patient and your perspective on whether you'd like to take medications or not. And I think, you should have the decision-making power, to a certain degree in the doctor-patient relationship. All right, hallucinations are another symptom of Parkinson's disease, or the medication taken for Parkinson's disease, that can be pretty scary. And oftentimes these happen at nighttime. It can be from the Parkinson's itself. It can be from medications that you take. It can happen as a result of a urinary tract infection or a pneumonia. And typically are worse at night, but it can happen throughout the day. And I've heard some patients say, "Doc, I see a shadow out of my eye." Other patients have said, "I see a little cat in the corner of the room that other people can't see." And then, I've had more extreme examples where I think the first talk I gave on sleep and Parkinson's disease, I had a patient who said, that he looked to the side of his bed and he saw a deep canyon, which frightened him to get out of bed because he thought he was going to fall into that canyon to his death. And so, that these can be very complex and they can be very simple. So it kind of takes a little bit of discussion to figure out exactly, what is a hallucination if you're having it. And as I mentioned, hallucinations can be disturbing or frightening. They can prevent sleep if you feel that there's somebody in the room watching you. And then they can also cause problems for caretakers, especially if the hallucinations that the patient is seeing are threatening, and they're fighting off these hallucinations, or patients are getting aggressive as a result of seeing these, these visual disturbances. And so, the treatment of hallucinations really depends on the cause. If a patient has an infection, then I think the easiest thing that we can do is try to treat that infection in order to reduce the hallucinations. If a patient is experiencing hallucinations in response to a medication increase, and these specifically would be the dopamine replacing medications for Parkinson's, like Sinemet, Ropinirole, Pramipexole, Nupro, which was mentioned earlier, reduction of that medication can oftentimes help. There's a little bit of a balance there that you have to strike, because if you reduce medications for Parkinson's, your tremor might come back, it might get worse, your stiffness, might be more prominent, walking problems might also be, rearing their head. So it has to be a balance and made in conjunction with your neurologist about that. But let's say none of those things are the case, and the patient simply is having hallucinations because of Parkinson's disease, then there really are 2 medications that we commonly use in order to treat that. One is called Seroquel, or quetiapine is the generic name. It's a medication that's very well tolerated. It tends to have a very low side effect profile, but can create a little bit of fatigue or sleepiness. So that's usually the one that we start with. Folks may have seen these commercials for something called Nuplazid, which is a medication that was FDA approved probably about 4 to 5 years ago now, specifically for hallucinations and Parkinson's disease. And it's often difficult to get this unless you've tried another medication first, but that's a medication that can be very helpful as well if you're having hallucinations. So again, if this is a problem that you're dealing with, please speak with your physician about that. I wanted to touch a little bit about the motor symptoms of Parkinson's disease and what we call wearing off. And at the beginning of the talk, as I was talking about the opportunities for involvement in clinical trial, we sort of defined what off time meant. And that means that if you get a response to your anti-Parkinson's medications and you start to feel that your symptoms of tremor or stiffness come back before your next dose of medication, then we call that wearing off of your medication. And this can happen during the daytime, but it can also happen during the night. And it can be anything from tremor, stiffness, or feeling rigid. And some people who experience what's called dystonia, which is an abnormal muscle contraction that can lead to a big toe curling up. It can lead to, the foot curling in one way or the other. It can lead to fingers also having an abnormal posture, as well as even your neck being in an abnormally spastic position. So all of these things can result from, your medication wearing off, and usually occurs because of too little medication. And so the impact of this on your sleep is that it can cause significant discomfort, of course. It can also wake you up in the middle of the night. And so this is something that we also want to know about if you come into the clinic. The treatment of this really focuses on adjustment of or change in medications that are commonly used for treatment of Parkinson's disease. And many people are on a short-acting medication called Sinemet or any of the other dopamine agonists, but there are long-acting medications that can be helpful and have been shown to reduce off time during the night. One is called Sinemet controlled release, or Sinemet CR for short. Another is called Azilect or Rasagiline, which is a once-a-day medication that helps to supplement the Sinemet or carbidopa-levodopa that you already take. And those have both been shown to be helpful for managing, off time during the night. Now, if somebody is having one of those abnormal sustained muscle contractions and the medications aren't doing the trick, then, movement disorder specialists like myself are trained in Botox administration. And many people are familiar with this for, wrinkles in the forehead or, wrinkles around the eyes. But Botox was actually initially used for treatment of neurologic issues, and dystonia being one of them. So that could be a potential treatment as well. Finally, deep brain stimulation is something that can help for off time. And this is not specifically used for wearing off just at night, but if a patient is, taking medication and they're finding that that they're not getting the length of benefit from that medication that they used to, and they're finding that they're having more off time during the day, then deep brain stimulation should be brought into the discussion. And in the major clinical trials that looked at deep brain stimulation for somebody who is having off time throughout the day as well as dyskinesias, actually, patients in those trials had at least 30 minutes to an hour of an increase in sleep time. So there's something about the way that deep brain stimulation either treats the tremor or the stiffness related to Parkinson's disease or creates another change that can help with sleep. So, we also do that at UCSF. We implant a fair amount of deep brain stimulation and are one of the biggest centers on the West Coast for that. And so if this is something that, again, if you're experiencing off time during the day, as well as dyskinesias, it would be worthwhile to speak to your neurologist about that, if that's a possibility for you. Okay, so I'm actually right on time here. I've got about 5 minutes, and we're coming to the last part of the talk. And I want to talk about one common sleep disorder that can impact Parkinson's disease, and this is sleep apnea. I think next time I'm going to have an audio clip or a video of somebody snoring really loudly, but you can see that the bed partner of this patient really is kind of upset because presumably this guy is snoring really loud, and she can't get sleep as a result of that. And so what is sleep apnea? It's significant reduction or complete stopping of breathing during sleep. Many patients with sleep apnea, snore at night. A bed partner might actually hear a pause in breathing where the patient stops breathing completely, or it sounds like they're choking. A patient may experience multiple awakenings at night, which also may be accompanied by coughing or choking. Daytime sleepiness is a major symptom of sleep apnea, and that may lead to taking multiple naps during the daytime. And so if you have a combination of any of these symptoms, it's very probable that you have sleep apnea. And the impact of sleep apnea in Parkinson's disease has been studied. One is that it can cause significant daytime sleepiness, which already is a problem, from Parkinson's disease itself, or even the medications that are taken for Parkinson's disease, like Sinemet and Pramipexole and Nupro. Sleep apnea also, can lead to other medical issues like high blood pressure, diabetes, strokes, irregular heart rhythms. And specifically in Parkinson's disease, sleep apnea can worsen cognition or memory. So it's really important that if you have these symptoms, to bring it up to your physician. The diagnosis of sleep apnea typically is made with either a home sleep test or an in-lab sleep test. I don't actually know how many of the sleep clinics are functioning right now, but I would assume that that a home sleep test could still be done, in this shelter-in-place period. So, that's something to consider. And generally, to test for sleep apnea, you have to be referred to a sleep specialist in order to get that done. So, the treatment of sleep apnea really focuses on a CPAP machine. And for those who are not familiar with what a CPAP is, a CPAP is basically an air compressor that helps to administer, pressurized air to you throughout the night. And many patients will wear a mask that connects to the machine. And what that air does is it acts as a splint for, your breathing system. It helps to splint open your airway and helps you to reduce snoring and reduce those pauses in breathing that might be happening. Now, if CPAP, isn't the treatment for you, if you don't like wearing something on your face at night, or if you feel claustrophobic, there's certainly other treatments that are available, which, admittedly are not as effective as CPAP. But things like an oral appliance, which is almost like a mouth guard for your top and bottom teeth, but helps to pull your lower jaw forward and stabilize your airway. That's one possible treatment. Nasal strips, like you might see athletes wear, it's a strip that goes right over the nose and helps to open up your nasal passage, can be helpful. Allergy treatment can also help to reduce obstruction, from allergies or sinus problems. And then there are a number of patients who, aren't getting adequate relief with some of these treatments and simply sleep with multiple pillows or a wedge pillow. I've had patients even say that they sleep in a recliner. And by removing the effect of gravity on your breathing, on your airway, that can also help treat sleep apnea. So again, if you feel like you have any of those symptoms, please bring that up with your physician and get treated for it. So that's the end of my talk. I think we're right on time. It's 1:59. I wanted to thank, Mark and the group for having me today. I wanted to also thank Jeff Solomon from Boston Scientific for connecting us. And this is just a slide of our team at UCSF. We really have a multidisciplinary approach to treating movement disorders and Parkinson's disease. So we collaborate with, our neurosurgery team, our neuropsychology team. We have a big research staff that helps us, but we have a lot of neurologists that are really invested in taking care of patients with Parkinson's. We're really invested in taking care of patients with Parkinson's. And, if your neurologist office is closed, or if you don't have a movement disorder specialist, by all means, please reach out to our clinic and we'd be happy to take care of you.